we move to the last speaker of this webinar. And she's also a pediatric radiologist, Susan Beck from Philadelphia, and she will give us an overview and also the insight in their experience with contrast in bladder and this voiding sonography and reflux pathology. Please, Susan.
Thank you. So thank you for allowing me to participate in this panel. I am going to be talking about the administration of contrast into the urinary bladder, primarily for the assessment of reflux, but we'll talk about some other indications as well. Lumasan and SonoView now have regulatory approval to be used to instill into the bladder, but all other contrast agents are currently considered off-label for this indication. And at the present time, we do have a support from BRCA to teach about ultrasound contrast. So contrast-enhanced voiding urosonography, I'm going to review now what to do, what not to do for this procedure, and examples of what it looks like. So what is it? It's very similar to doing a VCUG, conventional VCUG, when you're looking for vesicoureteral reflux. The major differences are the ultrasound contrast agent and the ultrasound modality. The benefits to using ultrasound for this setting is that there's no radiation. It's very sensitive to the detection of reflux, which I'll discuss. It's child-friendly, so the equipment used for ultrasound is much more favorable than that used for nuclear medicine investigations and for fluoroscopy. In resource-limited areas, ultrasound is potentially more accessible than either of the other modalities. And as has been mentioned by the other speakers, it's a very small volume of contrast that's utilized. So potentially, if you are in a institution or location where you can use a vial for more than one patient, there's a great benefit. And in the voiding examination, the patients can void in a more physiologic position, either seated or standing potentially, which is favorable for the child. So how is it done? The exam is best done by at least two people, potentially even three, and it does start with a sterile catheterization of the bladder, and the urinary bladder is emptied of the urine. There are two main ways to administer the contrast, either by infusion or injection. We've tended to use the infusion technique because it's been more reproducible for us, but I'll review how to do both. And then you need dedicated ultrasound settings to be able to view the contrast, and that's mostly for the longevity of the contrast agent, so the bubbles last long enough to perform the examination. So how is it done? If you're going to use the infusion method, you start with saline. You have to determine what's available in your institution, the size of the saline bag, but you're also going to take into account the size of the child and what their bladder capacity is. If they're a larger child and they require a larger volume to reach their bladder capacity, you'll need more saline and more saline available. If they're an infant and they're going to void frequently, you might have to do a cyclic examination, and you'll have to account for multiple fillings of the bladder. And like the other intracavitary experience, we also use a very low percentage of contrast, and we found using a 0.2% solution of contrast mixed into saline is optimal. So that's essentially a 0.5 milliliter of contrast into a 250 milliliter bag of saline. So then once the contrast is mixed into the saline, we connect the tubing. We do use a gravity method. We do prepare some extra saline to have on the side, and I'll show you what that's utilized for. And then we connect the circuit. So here we have the ultrasound contrast solution, the IV bag, which will then connect. We use a three-way stopcock. The patient bladder catheter will enter here at the 180-degree portion, and we have additional saline available at the 90-degree port in case we need to dilute or to mix the contrast further within the bladder. And then finally, we connect to the urinary bladder. If you're doing the injection technique, certainly you start with the bladder catheterization of the patient. We again utilize a three-way stopcock. You would draw up your contrast agent. We do instill some saline into the urinary bladder so that it's not completely empty when you're instilling the contrast agent. You then inject the contrast, and you could follow it by a saline infusion to gravity to help facilitate the mixing of the contrast in the urinary bladder. An alternative to using gravity is to use a pressurized bag, which is beautifully described by Dr. Duran and her colleagues, using a blood pressure cuff to pressurize the bag, and that's another alternative. So next you need an ultrasound contrast package or software to be able to optimize the visualization of the bubbles. So this is typically a low mechanical index setting, and depending on the vendor that you're using, there are other technical features such as a color overlay or background subtraction or a dual display, and each of these aspects are to be able to increase the user's visibility of the contrast agent and the pathology. One thing to be mindful of is when you're changing from your diagnostic grayscale image, so this is an infant who has a high-grade urinary tract dilation, and we're preparing to do a voiding examination, you go from the diagnostic grayscale image to the contrast mode, and you'll note that there's decreased resolution of the kidney in this image. And so you shouldn't be alarmed by that, knowing that both the contrast, the subtracted contrast image, as well as the grayscale image are both decreased MI, so there's decreased resolution. But having the dual display does help the sonographer, the imager, remain on the kidney during the examination. And this is one reason why it's very helpful to do a contrast mode image of the kidney before you instill the contrast to understand what the anatomy will look like in the contrast setting. So the benefits to doing this examination and evaluating the kidneys is that by ultrasound, as opposed to the other modalities, the child can either be supine or prone. You could do both depending on what's necessary to depict the anatomy or the pathology. And the child can sit or stand to void. We found that using a training potty has been very helpful for those children who are already potty trained at the time of the examination, including older and school-aged children, and those who request privacy or modesty when they're voiding. They find it difficult to void in the environment with all of the providers. So we've had children seated, we drape a towel over them for modesty, and are still able to image the urethra underneath that towel or that drape. And we've even had success using this potty for children who are sedated with the assistance of the care providers and parents to help seat them on the potty. And then the technique is to alternatively scan the right and the left kidney. So some pitfalls. When you begin the examination, we do a preliminary image of each kidney, and you use this to identify the best sonographic window for each kidney, and you want to be able to set the parameters on your ultrasound. And so here, there's excessive suppression of the kidney, and this is potentially too excessive. You want to be able to see the anatomy and understand where you're going to expect to see the reflux in the central aspect of the kidney on your contrast mode. If it's incomplete, you will have these reflections from the renal sinus, and potentially it could be confusing. So you want to make sure to suppress at least some of that signal. And so something along the lines of this image would be more optimal, where you have an idea of where the kidney is, you can see the central aspect of the kidney, and then you're set to go. So this is back to that infant where I had initially shown you the image with high-grade urinary tract dilation. This is our pre-contrast administration image of his right kidney. We've set the parameters. We feel comfortable with the way that the kidney is depicted in contrast mode. We then switch over to the left kidney and do the same. And then we turn our attention back to the urinary bladder, which is already containing the catheter, but still has a little bit of urine, and that's okay. In fact, if this urinary bladder was completely empty at this point in time, we would probably instill a little bit of saline so that we are confident that we're imaging over the urinary bladder and that that volume of saline could receive the incoming contrast or contrast solution. So then at this point, we turn on the contrast. And here the urinary bladder is filling with the contrast solution. You can see the shadowing from the catheter, which is in place. And then we're doing gentle transverse and sagittal sweeps through the urinary bladder, watching it fill and looking through the bladder to find the distal ureter. So it's optimal to monitor the bladder filling, because whatever's contained within the bladder, if this child does have vesicoureteral reflux, that's the material that's going to reflux into the upper tract. So you want to make sure that for optimal bladder filling, you have a homogeneous distribution. So the contrast agent is evenly distributed throughout the bladder, as it is here. That you have no acoustic shadowing. So that can occur, as has been mentioned, when the contrast concentration is very high. And if that's the case, you would not be able to see through the urinary bladder and to the posterior bladder space. And so it's also very important to be able to visualize that bladder base to detect pathology and to be able to see the ureter. And so here we can visualize the retrovesicular space, and you see the right ureter is filled with contrast, and actually we're able to depict where it inserts upon the bladder. And here are images from that examination in real time showing both the reflux and the intermittent drainage of the contrast back into the urinary bladder. There are some pitfalls in filling the urinary bladder. One that was written about some time ago is using normal saline that has come from a vacuum-sealed saline bottle. So the process of the vacuum sealing when it interacts with the contrast agent, the ultrasound contrast agent, can result in bursting of the bubbles. So if you do have glass saline, glass containers containing saline available to you, you do want to select saline that is packaged within plastic for this examination. Another reason why you may have suboptimal contrast within the bladder is about the way you administer it. So as I had mentioned, we use the three-way stopcock. And whether you do or don't, you want to make sure that the contrast agent is always in line with the urinary bladder. And that's because if you administer it at the 90-degree port, turning that angle causes some shearing stress on the bubbles and can result in contrast loss. So you want to stack the odds in your favor with optimal contrast that you're administering to the patient. Potentially, if you don't have adequate saline mixing with the contrast or flushed behind the saline, you may have a layering effect. And so in this patient, perhaps if you had a little bit of agitation with saline, it would mix more homogeneously and fill the bladder. As I had mentioned, if you have too high of a concentration, you'll have posterior acoustic shadowing and you'll have the dropout of sound behind the near field. You want to confirm that your scanning parameters are correct. Make sure that you're on a contrast mode. If you have increased MI or a high power setting, you may burst the bubbles. And depending whether you have the ability to use a multi-dose vial, we don't have that ability here. We have to use one vial per person, but the contrast agent could potentially last for a 24-hour period of time. So you'd want to know what the age of the vial is and when it was opened. And lastly, if the patient has had to undergo an examination just prior to your voiding examination that involved intravenous administration of contrast that's going to be excreted by the kidney into the urinary bladder, you'll have a layering effect, and therefore the higher density contrast will be in the more dependent position, and that agent would be more likely to be the refluxing material, so you could potentially miss reflux. So when we schedule these patients, we make sure that they do not have these examinations immediately prior to the voiding examination. So after we had adequately filled the patient's bladder, whether or not you've identified reflux in the distal ureter, then you turn your attention up to the upper tract. And here this is a high-grade vesicoureteral reflux into the right kidney. And we're doing gentle sweeps either in a coronal or sagittal plane to be able to depict the high-grade reflux. In a dilated system, it's much easier to depict the reflux because you can very clearly see the spaces where you're expecting the contrast agent to go. So on the previous image, we had just the single display. You don't need to have a dual display if you're confident that you're over the area of pathology. And here we had switched back to the dual display as we were trying to trace the ureter down from the kidney to the bladder. And we use the grayscale image to help guide our positioning to do so. After you've imaged the right kidney, then you move over to the left kidney, and fortunately this patient did have bilateral reflux with a lower grade on the left. But here you can also see the left kidney extending to the left ureter, and as we're trying to scan down to show the communication to the urinary bladder. And when the patient's able to void, so this young man is obviously too young to let us know he was able to void, but we have multiple people in the room helping with the examination. So someone is observing for when the patient starts to void, and at that point in time, we turn our attention to the urethra, this from a suprapubic approach. And following voiding, we would then go back and re-image each kidney to look if reflux had not happened pre-void to see if it happened post-void. So once reflux occurs, you want to be able to grade the reflux, and we do so in a similar way to the International Reflux Grading System. It was first proposed some time ago with this chart, and I'll show you some more recent examples. So the description is very similar to the international classification. So grade 1 would be microbubbles that were only visualized within the distal ureter. Grade 2, the microbubbles extend up to the renal pelvis. However, there's no significant pelvic dilation. Moving up to grade 3, you have more significant dilation of the pelvis and moderate calyceal dilation. In grade 4, you have more significant calyceal dilation and have begun to lose the pelvic calyceal contour. And in this case, we had some tortuosity of the ureter. And finally, at grade 5, you're losing the pelvic calyceal contour and likely have a very dilated and tortuous ureter. And we have found using this 5-grade system helpful, especially for our clinicians, because they're accustomed to the 5-grade system that we've been using for VCUG. So it's an easy and natural conversion for them to understand how we're interpreting these examinations. So there are inherent challenges in imaging reflux in general, and some benefits and challenges to each of these modalities. And I think the first and foremost is that reflux is intermittent. So you're able to see it if it's happening at the time of the examination. When you do ultrasound, you have the opportunity to do more continuous scanning because you're not exposing the child to radiation. However, we can only look at one kidney at a time unless you're in a position to be using 2 separate ultrasound machines at the same time. The ultrasound has some benefit in being able to depict the anatomy, so you know whether the urinary tract is dilated. And as I had mentioned, it's somewhat easier to see the ultrasound contrast agent reflux into a dilated system versus the X-ray contrast agent, which becomes diluted, especially in a dilated system. In the ultrasound examination, it can be a challenge to see the ureter, but you can certainly easily depict the reflux up into the upper tract, and I'll talk about the comparison in terms of grading between the 2 exams. And then with any new modality or new technique in your department, there is a learning curve for folks to feel comfortable in performing the examination. So how does a VCUG compare to avoiding examination? Well, this is a meta-analysis which was performed regarding first-generation contrast agents. And the generation just refers to over time in development of these agents, the newer agents, which are now second-generation agents, are more stable and so last longer. But in this meta-analysis with about 2,800 kidney ureter units and just shy of 900 with reflux, there was 19% detection of reflux was only seen by ultrasound, whereas 10% of reflux events were only seen by VCUG. So in this comparison, there was a benefit of seeing 9% more reflux by ultrasound than there was by VCUG. And in these studies, of the ones that compared both modalities by a 5-grade system, they did compare favorably. So there was a lot of agreement in terms of the degree and the grade of reflux. But you'll notice that up to 70% of reflux that was categorized as grade 1 by VCUG was actually of higher grade when it was diagnosed by ultrasound. And that potentially has a clinical advantage. Looking at second-generation agents, there have been several studies that have compared these 2 modalities head-to-head, and each of them have shown favor for ultrasound, being able to detect more reflux by ultrasound than by VCUG. And similar, the reflux grades that are missed by one modality, so the ones that were missed by VCUG tended to be graded higher on ultrasound than those that were detected only by ultrasound tended to be noted to be lower grade by VCUG. So I'd like to share with you a clinical example, and this young lady was one of the first exams that we were able to perform here clinically, and she was a 4-month-old full-term infant who had a febrile urinary tract infection and had a renal bladder ultrasound and had this conventional VCUG, which depicted that she had a duplex left collecting system, and she had grade 3 reflux into that lower pole collecting system. She was followed with antibiotic prophylaxis, and when the time came for her to return for clinically indicated imaging, she was about 18 months of age, and we were just introducing contrast-enhanced voiding ureasonography into the department. She'd had her renal bladder ultrasound that day, which redemonstrated her duplex left system. She still had some urinary tract dilation, and at that point, the family was very keen to avoid radiation and was told about the option to have this done by ultrasound in the coming weeks and months. And they actually decided to defer the VCUG that day and return several months later for her voiding examination. So this is an image of us filling her bladder. She's now 24 months of age. The bladder is instilled. You see the contrast agent flowing into the urinary bladder. Now we're turning our attention to that left duplex kidney, and you can see very nicely the reflux into that lower pole of the left kidney. And we're able to turn her prone. And once again, you can see how the collecting system changes in that prone position, but nonetheless still with about a grade 3 reflux. So in comparing her original VCUG at 4 months of age to that of 24 months of age, if you just turn the ultrasound image sideways, you can see that it has a very similar depiction of ultrasound and VCUG. So at that point in time, she was again going to follow up, and actually in the more recent weeks she has, and with persistent reflux in her clinical scenario, is going to have to go on to a surgical repair. So in addition to looking at the kidneys and reflux, it's also important to note that you can adequately assess the urethra, and you can do so both by a transperineal and a suprapubic approach. If you're just beginning to use this modality to evaluate reflux and the urethra, you may want to choose patients who are coming for follow-up, or female patients where the urethral pathology is less common, so that you can practice doing this technique. But something else that I found is helpful is for all of these patients, they have a transurethral catheter in place, and while you have filling of the bladder, you have contrast moving through that catheter, and that gives you an opportunity to use that catheter as a landmark to find the correct positioning of the transducer on the patient's abdomen or perineum to identify the urethra. And there's a recent pictorial demonstration of excellent examples of urethral pathology that you should look up. But just some other examples, in addition to looking at the urethra during a reflux examination, you could use contrast ultrasound as a primary modality to look at the urethra. And in this case, the 17-year-old boy was diagnosed with a urethral stricture, and this is his conventional imaging. He has a suprapubic catheter in at this point, and they were planning to return to the operating room to fix this stricture. So we were able, with ultrasound as a portable modality, go with them to the operating room to re-demonstrate the urethra and the bulbar stricture pre-op, and able to follow him up post-operative. And he certainly could come to the department post-operative should the urethra need to be re-imaged. Along a similar vein, this 5-month-old girl who had congenital CH and ambiguous genitalia, there was concern that she had a urogenital sinus. So this is a transabdominal image showing the urinary bladder is somewhat decompressed. This is fluid distending the vagina, and here's her uterus. So we did fill the urinary bladder retrograde with ultrasound contrast. And then as the patient is going to start to void around the catheter within the urethra, you slowly start to see contrast filling the space behind the urinary bladder. And this is in real time. You could see that there was a communication between the urethra and the vagina, which was filling with the dilute contrast. So in the same setting, to help demonstrate to our clinicians the ability of ultrasound contrast to depict similar anatomy, we did also do a conventional genitogram, which you can see the contrast filling the vagina with a similar communication to the urethra that we were able to see with the ultrasound contrast exam. So in summary, I've reviewed how to go about doing a contrast avoiding urography, some pitfalls to be mindful of, and through some case examples, hopefully have piqued your interest in either expanding your current use or beginning to use this as a modality for reflux evaluation. I've mentioned some references in the talk, but also that the SPR and ESPR have a lot of other resources if you're considering expanding your use of ultrasound contrast, particularly in children. Thank you.
Thank you, Susan, for very nice images of these urogenital locations. And I wanted to ask you, is there any difference in terms of scanning if you preliminary have seen already the dilatation of calyceal system? Would you more go on the focus of the distal ureters then, or you still would follow the protocol, being sure that the hydronephrosis is in mega ureter stage?
Mm-hmm. We tend to stick to the protocol. If you have a megaureter, you are more likely to be able to see the contrast agent move into the ureter. Sometimes it can be challenging with seeing the echoes reflective of the bowel and the stool behind the urinary bladder. But when you have a megaureter and you're in the contrast mode, it's easier to see. But we do look first for the distal ureter, but if we do not see reflux into a distal ureter, move on to the kidney. And sometimes then when we're up at the kidney, then as I had shown to come from the flank to try to follow the ureter all the way down.
Okay, and there are questions about, do you have any issues in visualizing contrast, knowing that we use higher frequencies in children in pediatric ultrasound, and is there a general recommendation about selection of these frequencies?
We have not had difficulty. We have also, as the other folks have talked about with the concentration of contrast for intracavitary use, we're still using a 0.2% solution primarily. We're using the ultrasound transducers that we typically would use to image the kidneys. We use very frequently a curved 2.9 transducer. We've actually found that we can very easily see the urethra. We don't need to switch to a linear transducer to be able to see the urethra. We have adequate visualization with that curved transducer, so it has not been an issue for us.
And what do you think about this antibiotic prophylaxis? Is there any need for that? And is it enough? What is your typical approach?
So we don't make specific recommendations for antibiotic prophylaxis. We leave that to the treating pediatrician or the urologist to determine what the medical management should be at the time of the examination.
Okay. And what do you think? We know there are also a lot of problems in adults, also with urethra strictures. Would you think it would be feasible also not to have this intracavitary use only in pediatric population, but also maybe in complicated cases in adults?
I am not sure that I can speak to the full realm of adult pathology based on my practice, but I think it's certainly possible. I mean, the adolescents that we have had the opportunity to scan their urethra are adult size and use a transperineal approach, and we've been able to demonstrate at least strictures. I think it depends on what you're looking for and whether the field of view that ultrasound affords you is appropriate for what you're looking for. But I think it would be an exciting direction for someone to undertake.
May I ask you about the best age you think is the most cooperative, the best age for all sites when maybe the first assessment of this reflux and this pathology, or maybe also urethral pathologies we should go for?
I think that's always a challenge. I think as soon as you think a patient is going to be cooperative, it winds up the opposite, and the ones that maybe you think won't be sometimes are the most cooperative. So sometimes that can be quite a challenge. I think if you're just starting off, potentially the best way to go is to do patients who are coming back for a follow-up examination, especially in regards to looking at the urethra. Some folks might have the opportunity to do an exam head-to-head with fluoroscopy. So if you're trying to gain confidence and the confidence of your referring clinician, to offer them both examinations in the same setting to see if you're able to depict the same pathology. That way you have the backup of the VCUG. There's several ways that you could go about this, but potentially a baby would be an easier patient. I think the hardest are the toddlers or those who are around potty training who find it difficult to void in this setting or who are old enough to understand what's happening.
How do you deal with those patients who are not cooperative because the pathology is there, they need the diagnostics? What is the alternative approach in those cases? Would you reschedule them for some next session and negotiate in between, or you choose other modalities? What is the approach in non-cooperative?
Sure. Well, I think if they're not going to be cooperative for VCUG, they're probably not going to be cooperative for ultrasound either. But the benefit to ultrasound is, especially in a child who might be anxious or nervous, that the parent can hug and comfort, or caregiver can comfort them, and they're not obscured by the big fluoroscopic tower and some other limitations in that environment. So it is a more friendly environment. We also are very fortunate to have child life specialists who help coach the family and the child through the procedure before it happens. We do a lot of discussion about what is going to happen. It still is an option for families to talk with the referring provider as to whether sedation is warranted, and we do offer these examinations with sedation. And so those are all possibilities. And sometimes a child doesn't void. That happens with VCUG as well. But at least with ultrasound, I've had toddlers be held by their parents, and we've scanned from their back. So even if we haven't been able to see the bladder or the urethra, especially on follow-up examinations, we can still look for reflux up into the kidney. So say they had a very easy examination as a baby, and now they've come back. They're a little bit older, so they can be held by the parent. You can scan through the back to look for reflux into the kidney.
Okay. And the last question from the audience is, do you have an experience or maybe potential use of contrast in undescended testes cases? Have you tried to look for those undescended testes by the help of contrast enhancement?
It's an excellent question. We have not to this point. I think we are fortunate to have excellent sonographer staff and physician group. You know, we try our best to look by grayscale. I think you might meet some challenges with BAL depending on where the testis is located. So if you're unable to find it by grayscale, I'm not sure how much better contrast would be. Potentially, if you see something and you're not sure what it is, there might be value, but I don't have personal experience.
Okay. Great talk, Susan. Thank you so much for sharing also the all actual literature to those who just begin this procedure. And thank you for your address, so some of those who are interested in more practical approach may reach you.